Good morning, everyone, and thank you for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by the Center for Substance Use Training and Telementoring, CSTAT, at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate the bottom of your Zoom window and select the Show Captions option. You may need to click on the three dots More menu at the bottom right of your Zoom screen to find this. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Beeville, Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your phone number and name to beeville@ithaska.edu. Also, please note that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any info you put into the chat will not be shared in the recording. We encourage everyone to join by video, especially for the discussion portion of the session. That said, regardless of how you've shown up today, we are just happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6. You can also use the reactions menu at the bottom of your Zoom screen to raise your hand and indicate you have a comment or a question to share. You can also use the chat feature to share your comments and questions. There are a lot of us in the space, so please keep your comments brief to allow the others a chance to speak up as well. And finally, please note that no protected health information is allowed in either the chat or in the discussion, and that includes names, addresses, dates, pictures, or any information that can identify a person. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it also allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Jac A on strategies for deflection for PWUS in the judicial system. Following that, we will hear a case presented by Shannon Churchwell. There are a lot of professions represented here today, a lot of experience and perspectives. I encourage each of you to share that during our discussion so that we can all learn from each other today. And with that, we will start with some introductions. Jeremiah.
Hi, everybody. I'm Jeremiah Golka. I'm the Executive Director of the SHIELD Training Initiative. I'm based out of DC and Boston, but love zooming in to spend time with you all. We do occupational safety and health training for police, criminal justice folks, fire EMS, connected to work responding to the overdose crisis and stimulant crisis. Looking forward to the conversation today. Thanks.
Thank you so much. Cynthia.
Good morning. My name is Cynthia Mendiola. I am a retired federal probation officer. I currently work with a training group in helping probation officers with core correctional interventions. And I'm excited to be here and also excited about the presentation. Thank you.
Thank you so much for joining us today. Jac A.
Sounds good. Good morning, everybody. My name is Jac A. I'm the Executive Director of that thing you see over my right shoulder, which is TASC, Center for Health and Justice. More later, since I'm doing the presentation today. Thanks for allowing someone not from Texas to be with you.
Well, thank you so much for making the time to join us today. Shannon Churchwell.
Okay, hi, I am Shannon Churchwell. I've been in the fire department in San Antonio for 19 years. 12 of those years as a paramedic, mobile integrated health for mental health and also substance abuse teams for the last 4 years or so. I'm happy to share, the case and scenarios that we experience almost on a daily basis and hopefully gain some information and some resources.
Thank you so much for joining us, Shannon. Dr. Miramontes.
Recording in progress.
Howdy, Dr. Dave Miramontes calling, and I'm your cruise director today. And so I'm gonna actually on the other, there we go. We're battling with the audio here in the room. So I'm your cruise director today. I will be taking notes and do some reflections afterwards and helping Shannon out with her case presentation. I'm the medical director for the San Antonio Fire Department. I do a lot of addiction medicine as part of my job, and we're here to help as best we can.
Thank you so much for joining us today. Andrea Hebler?
Hello, everyone. My name is Andrea Hebler. I am one of the program coordinators at the Center for Substance Use Training and Telementoring, CSTAT. Welcome, everybody.
Thank you. And with that, we will move on to our didactics for today. Jac, whenever you're ready, you can take it away.
Okay, that sounds good. Thank you very much. I'm going to get this up on the screen. There we go. Cool. All right. Okay, just want to make sure someone just shout out. Can you see the screen? Full slide. We're all good?
Yes, we are.
Okay, good. All right, I'm going to start the timer here. As I said, thank you again for allowing me to be here. My name is Jac A, Executive Director of TASC's Center for Health and Justice, and I'm also the Executive Director of the Police Treatment and Community Collaborative, which is the global voice for the field of deflection, which is what we're going to talk about today. I do like to do a little bit of audience participation, so I'm going to use this word deflection. I can only see a few of you because I'm in presentation mode, but could you, by a show of hands, either wave your hand or click the button? How many of you have heard of the word and the field that's called deflection? Because it is a new field of study that'll help me understand when I'm presenting. So raise your hand, throw a shoe at the screen, something like that, and say, yes, I've heard of that. Okay, let me look at a few. Okay, just a few. Okay. Good. All right. Good. This helps me kind of know where to go with the presentation a little bit. By the way, when I present, I'm less concerned about getting through all the slides as I am into making sure that you walk away with something relevant and useful. And of course, this is the ECHO model, so that comes through the case study and what comes next. So again, thank you for allowing me to be here with you today. I'm going to present a new field of practice in the United States and internationally called deflection. It's about 10 years old, so it's very, very young. I like to say we're in about 3rd grade, so expect about a 3rd grade level kind of presentation, hopefully a little better than that. But it is reflective of this new approach, this new strategy for people with substance use disorder, SUDs. And when I say in the justice system, really it's about this early upfront encounter. I am not going to be speaking to courts, probation, prosecutors, parole, prisons, sheriffs, wardens, anything like that. I'm going to be talking about law enforcement, EMS, and no first responders involved in early, very early upstream encounters where drug use is probably driving the encounter. I'm also not going to be in the mental health crisis space. I want to make that important distinction, and you'll understand why in a second. So thank you for allowing me to be here today. It is a pleasure, and I do look forward to being with you in the discussion. Here is the disclosure statement. Since this is being recorded, I will move on from that, but I want to make sure that that is included. Our training objectives for today, I generally don't read these, but I will now again because I can't see you. So just to make sure, we're going to define deflection. That will kind of be the part that's fairly easy to go through, and how it's different from another D word called diversion. And if I were to ask you how many of you have heard the word diversion, I'm going to guess most of your hands have gone up, regardless whether you knew it within the justice context, the medical context, or otherwise. Remember, deflection is new, and I'm going to ask you, start following this presentation, to use the word deflection when you mean deflection and use diversion when you mean diversion. They are different things. The 6 pathways of deflection, and then very specifically, I was asked to bring up deflection in relation to reducing drug use and drug-related crime. My background is in law enforcement. I now work for an agency that links the justice and the treatment system together. So I'm not clinical by background. I don't play a clinician on TV, but I'm very familiar with kind of both of those worlds. And yet today we are going to have a little bit of a focus on the reduction of drug-related crime also. Okay, almost ready to get started. I want to share with you that if you like what's presented today and you think it's good and like this is super exciting, we do have the National and International Summit for Deflection coming up in Seattle, as you see there, October, November of this year. This is the global summit for deflection and pre-arrest diversion, which is another term that's sometimes used for the field, and that's fine. So I just want to share this with you, and this will be in the slide deck that you get afterwards. Okay, with that said, and by the way, if there's anything that comes up in the chat box people need me to look at, again, just let me know because I'm in presentation mode. So let's start with deflection, kind of only a few hands went up on what it is. And so I'm going to start right here. The easiest way to explain deflection is what you're going to see come up on the screen here, and that's this. In deflection, we're not waiting for nor needing these items that you just see right now. Much of the work previous to the kind of the evolution and development of deflection has been in these 5 spaces, all of which make sense, all of which we accept in the field of deflection as absolutely valid places where work should be going on. However, what we are also saying, and remember, this presentation is primarily in regards to law enforcement and to EMS and now other types of responders, but really has kind of a heavier law enforcement lean to the way I'm presenting it to you today. What we're saying, though, is that what you see come up now is we're trying to get earlier and upstream from those first 5 things on the screen. And we want to be in a prevention mode. And the data actually supports us being in a prevention mode. We'll talk a little bit more about that. So we're moving away from this idea, not saying it's not important, it is, but going upstream of those first 5 things that you see there. Oh, there we go. Good. Now, deflection. I asked you up front if any of you have heard of the word deflection. A few hands went up. If I asked you how many of you have heard of these words that you see on the screen, and I will, so how many of you have heard of these words? Just kind of raise your electronic hand, and I'll look at everybody. Raise your electronic hand, or go ahead and say, yeah, I've heard of these. Let's see what we get there. Do we get a different response? We had just a few. There we go. Okay, cool. Good. A few more people. All right. I'm trying to go through. Okay, we got a few more people looking at these, so good. So these are terms that you're probably much more familiar with and are based on the response to the question I just asked you. These are all forms of deflection. We say that because in contrast to diversion, which I'll define in a minute, and we've been doing diversion for 60 plus years, these all fit somewhere in that early upfront with not waiting for the overdose, not waiting for the crisis, not waiting for the arrest kind of scenario, but in different places and spaces. The right-hand side of your screen really kind of is more in the mental health space. And again, I'm not going to be speaking about mental health or really crisis today at all. The left-hand side is more the evolution of the field of deflection itself. But even there, it started kind of more in the space where we've got an arrest, what should we do? And we're even trying to get ahead of that. Regardless of which word you use, and I will ask you to start using the word deflection from here on out, what we're really trying to do, which you saw come up at the bottom of the screen there, is to give a third way for police, FR is first responder, you get that, a third way for police to act in lieu of making an arrest when otherwise the officer knows that she does not want to make an arrest here because she knows nothing's coming of it, or she doesn't want to take any action, right? Which is actually the most common law enforcement response. Most people do not know this. You all do because you are experts in your field. You all know that the most common response statistically across the United States in law enforcement takes no action. It's not a criticism. It's just a factual statement. And with deflection, we're offering then law enforcement, and again, first responders and other responders, but we don't want to think of response in a crisis sense. We're offering them a third option, a third way of understanding these encounters where drug use is probably driving it or is related to it, but we haven't reached any point, nor do we want to reach a point where an arrest is needed and a run on the ambulance to the emergency room is needed. We're getting to people early. And again, we'll talk a little bit more about that, but variety of terms. Again, I'm going to ask you to start using the word deflection because this is the tool that's being built into now law enforcement, EMS, and other types of folks who are out doing outreach and engagement. in the United States. Okay, now deflection versus diversion. And I apologize, some of the slide transition from the slide deck that we normally use to this is a little bit off, so I apologize for that. I want to acknowledge that. Deflection is what you see coming up on the left-hand side of your screen. You can already see I don't really read slides, so I'm going to just point out one item on here, and that is centered in community. Deflection is a community-based response. It is not a programmatic response. It is not a program that you put together and implement. It is a set of relationship between the community, the civic world, networks of providers, service, government, and citizenry that says, how are we going to respond to this thing called drug use in a way that fits our community, the resources of our community, and therefore deflection looks different across the 14 to 1,600 known deflection sites in the United States. It looks very different because it's not programmatic, but what they all have in common is it's centered in community. Now, that other D word that I've said a few times is diversion. I'm going to put up here. Many of you have heard of this, as I saw. Diversion is a word that really centers its practice in the justice system. By the way, for those of you in the medical realm, I know that you use the word diversion in a completely different context. This is diversion from the justice system after someone has entered it. What we are doing with deflection as a new field and a new movement in the US and globally is saying, if we get to people earlier, the opportunities, the outcomes, the costs, the resources, the effort needed to do it there is better all around. And I know all of you know that, so I won't say more on it, but that's really just the simple premise of deflection and why it is not the same as diversion. All right. We like to say also, and this should already be familiar from the presentation, it's an early upstream intervention. What you see on the screen is the Texas justice system. From left, that's the community, to right, where you've got parole and probation, right? And each one of those arrows represents kind of a way out of the justice system after you have entered it. That's the critical part. But in deflection, and this is just a visual way of understanding what I already said verbally, right? If you're like me and you like pictures, Jack likes pictures. This one will make no more sense if the way I did it earlier, which was just all text, didn't. This is just another way of understanding it. And as a reminder, this is set within the context of the justice system, but deflection does not require nor need, nor have any sense of you have to be justice involved. None whatsoever. It's actually the opposite of that if you think about it. So it's an early upstream intervention that, using what you see that just came up in yellow, right? And this is what everybody relies on, whether you're doing deflection, diversion, prevention, all the work you're doing relies on what you see that came up in yellow. At that space there, that left oval, that left yellow oval where it says police, and again, it says first responders. Yes, I know first responders are not part of the justice system. Just kind of go with it just for the visual. It works much better that way. That's the space and place where we can do what I just put up there, right? That instead of doing an arrest, instead of taking a no action, we now are offering to law enforcement an opportunity for deflection. In lieu of, and I say this where you see these other four ovals came up, the other D word, which is diversion, where people must have entered the justice system beforehand before we begin to act. I'll go into some of the statistics on this before we finish up. You are probably all very familiar with them, being experts in this kind of in and around this arena, but there's lots of good statistics that talk to us about, well, if we waited till diversion, what does that mean, right? What does that mean, and why would we in fact do it? As you see on the left-hand side there, again, where that oval is now growing to reflect the growth and development of this thing called deflection, again, in the US and globally, that what we're able to do then by focusing there is we're able to have new opportunities to reduce drug use and reduce crime. Again, part of what I was asked to speak on today is that intersect of those two. Okay, so with that said, and this is not a training on deflection, it's just an overview. If I were to say, draw deflection for me, what does it look like in the United States? What does it look like as it emerges globally? This is what you would see. Notice it's entirely in community. There is no jail, there is no lockup, there is no bail, there is no bond, there are no judges. It doesn't mean they aren't important. It's just that the person who is deflected will never enter the justice system. That's something different. That's diversion. And what we like to say in deflection, let me back up there a second. What we like to say in deflection, if you look at those middle boxes there, those dark blue boxes, and again, it's not a training on deflection. I know this can be hard to read, so you'll get this in the PDF follow-up, is each one of those boxes represents a form of deflection: self-referral, active outreach, naloxone plus, first responder referral, officer intervention, and around the circle, if you look around, it's a little bit hard to see. This usually has some animation on it that kind of highlights it. It will say community response, not community responders, right? We're not in the crisis space. Community response, which could be any type of outreach or engagement that uses and leverages the principles and elements of deflection. That what we're doing is keeping folks in community. We're getting to them early, upstream, in a way that does not require nor need the justice system. And for you in EMS, I'm going to also say, because some of the data is very similar to law enforcement as it is for EMS, EMS and fire, but EMS, we're also trying to avoid use of the emergency room when it's not needed, or when it's the path that is often taken and we get there and then the person's out 4 hours later and that's that. We're also avoiding that. For on the mental health side, we're avoiding then the need for institutional issues, institutionalization as a alternative. Why? Because we're using early upstream community interventions. I'll put up on the screen here, again, not a training. You'll be able to see these later. These are 5 of the 6 pathways. You can see those up top. This just gives you a very, very brief definition of each one. You can read those while I'm talking. Notice at the bottom where it says officer intervention referral. This is the only one that is limited, that law enforcement must be involved in. The reason is there is a form of deflection called pre-arrest diversion. Remember when I put up the PTAC, the International and National Summit for Deflection that occurs every year coming up in Seattle. We call it the Deflection and Pre-Arrest Diversion Summit because there is this space where an officer is able to make the choice. She can decide, do I want to arrest or do I not want to arrest? Now, deflection is not for use as a violent crime reduction strategy. It is not that. So I don't mean it in those terms. It is not for anybody who either by statute or public safety reasons needs to enter the justice system. It's not that. Deflection is these encounters where we know drug use and the drug-related challenges that go with that are really driving the contact for that person and for their family. And that's important because in deflection, and I'm just going to put up the next screen so you can read this. In deflection, that should be around community response, by the way. In deflection, we don't just focus on the individual. We take a holistic family approach, right? A family approach. Diversion and justice focuses on the individual. Why? Because when you enter the justice system, it is the individual enters. But the reality of the work that all of you know is family-based, not individual-based. So when we talk about deflection, we're talking about a family-based approach, and whatever family is, but the person is not existing on their own. And so our responses in deflection are not limited to just the individual. Might be kids in the home, might be a partner, could be all sorts of things going on that are ancillary to the drug use that's driving the issue that's causing the encounters, right? What is that range and totality of things that are out there? Okay, normally at this point, I would stop and say, what questions do you have? Because I tend to go through the deflection stuff fairly briefly. Again, if we were doing longer, we'd dive deeper into it. What I'm going to do instead, since I've been asked to hold questions till the end, I'm going to go through this. We'll finish up a little bit early. So just letting folks know we'll finish up a little bit early, I think. And then that might give us a few more minutes for questions. So let me jump to the issue here at hand that I was asked to speak about, which is drug use and drug-related crime. Deflection has 2 origins. One is racial disparity in arrests by police. The other one is the opioid epidemic. But it really was the opioid epidemic that accelerated and catalyzed the growth of this field. However, because it involves drugs and drug use and everything that goes with drug trades and drug markets, the reality is that there is a linkage between good deflection work and a reduction in drug use, of course, and drug-related crime. So this is what it looks like. And it is answering this question. Again, it's not the sole reason for deflection, but it's a critical element, is that police using a street-level strategy through arrest and enforcement alone, and you all know this is not new, cannot do 2 things that they have oddly been asked to do. And again, we all know this. They can't stop a person from using drugs or reducing a person's drug use, right? And if you can't do that, if you cannot stop that, you cannot stop the second thing that you see that just came up on the screen, right? You can't stop the drug-related activity for them, for their family, what's going on in the home and in around that area, and the drug-related crime from drug use. And the reason is, even though that we have known this for a long time, the reason is that we've not had a way to connect drug treatment with police. So you can see now in deflection, I've dived kind of deeply into this space of drug use reduction and drug crime reduction, which is an element of deflection. It does not, as you can see from the earlier definition, reflect kind of the entire all that's going on in the field. But just to speak to this, so here's some statements I'm going to show you that form, if you will, the logic model, the rationale of deflection as a crime reduction strategy. So the first one you can see there. Importantly, MH is mental health. Mental health, as we know, is not linked to crime or criminal behavior. Drug use, drug addiction is very much linked to criminal behavior. You can, again, you know all these because of the work you do, so I'll just put them up. That third one is important. Remember, in deflection, we are leveraging early encounters before anything has happened that would cause an arrest, a run to the morgue, an overdose. We don't want to be in that space. We want to be in the early space. And I'll still say more about that in a second before I finish up. Here we go. This one that you say come up here. Mental health and police have worked now together for many years. There's still tension there, but they've worked together for many years. We think of CIT, MRT, MCT, all these kind of approaches. But on the drug side, it's much more recent development, and that's where deflection really comes in to form these partnerships. So what's been missing is this bridge then between law enforcement and drug treatment working together. And without this bridge, by the way, you cannot do the work of deflection, which means you can't get at real crime reduction, drug use reduction, except for the points we've been using already. So this is the bridge from left to right. Notice again, we are in the community. We're not in the emergency room. We're not in the jail. Right? We're not in those spaces. We're in the community. And what we say is this bridge allows law enforcement and treatment to be connected. You've already heard me say that. For those who are here from law enforcement or in the public safety space, what deflection also allows is for the first time, we can now link public safety and public health in the drug space. Primarily, mental health has been this linkage, but because mental health is not related to crime and criminal activity, then it has not really provided the linkage that people have been looking for. And in the big picture, it's supply reduction, demand reduction. No concerns on that. That's kind of bigger picture kind of stuff. Just a few slides. If you're not familiar with drug use and drug-related crime and how they go together, just 4 quick slides. This is data coming from when law enforcement encounters people at the time of arrest. What you'll notice very simply is that the overwhelming majority of people that law enforcement encounter where drug use is present have never had treatment. But when they do have treatment, whether, and you can see that on the right-hand side of the chart, when they do have treatment, their likelihood of being encountered by law enforcement greatly reduces. It's obvious, you know that, but I wanted to share this with you because some folks might not know how impactful drug treatment actually is in reducing law enforcement encounters. We know this too. We've known this for decades, actually. When you reduce drug use, you get a reduction in crime and an increased employment of that population. No surprise. And actually, when we, and this is a little bit blurry to see, you can look at it on the PDF. When we actually look at certain types of criminal behavior and criminal activity, all of it goes down when people get a chance to access treatment. Selling drugs is here, shoplifting, arrests, and all sorts of illegal activity goes down. The left-hand side is before treatment. That's the dark blue bar. The right-hand side is after treatment, after a year of treatment. It all gets reduced. And again, no surprise, but I just want to share this with you because some folks might not be familiar between the difference between mental health and crime and drug use in its relation to crime reduction. And interestingly enough, even violent crime, while deflection is not a violent crime reduction strategy, even the violent crime rate drops as we do more and more investment into treatment. Again, we've known this stuff for decades. It is not a surprise. We generally in the US have not applied it. However, we've not done it and hence enter the field of deflection so that we can do it in a community setting. It's not been where we've spent our energy and time for the most part. Okay, let's head to the end here. So this is the same bridge you saw before, right? And don't worry about all the text on there. Same bridge, law enforcement on the left, treatment on the right. Deflection has now finally formed this bridge that never existed before. And since it never existed, there's a lot we could not do. Now we can get at drug use reduction and drug-related crime reduction. And by the way, keep families intact. By the way, get to people earlier. By the way, help them maintain their jobs and their family connections in the community. By the way, make officers safer. By the way, reduce the time that officers spend on scene processing arrests or taking no action when they know they're coming back in 3-4 weeks. And now it's going to be a morgue run. Now it's going to be an arrest, right? Deflection gets at all that by getting to people early. Interestingly, for police, all we want is that left-hand side. We want to leverage their contacts. The police do not run deflection. They are a part of it where we leverage those encounters they have. And on the right-hand side, everybody else, treatment, housing, services, recovery, they're the 9/10 of deflection, where we are, in fact, leaning into them for the interventions that cause the change. And I know you all know this. I just want to be clear. This is not a police program. It's not a program. It's not a treatment program. It's a set of relationships that together foster this deep, relentless engagement that allows the deflection bridge to finally come into being, connect law enforcement with treatment. And I'm using treatment as a proxy, treatment, housing, services, recovery, community, all that stuff finally allows this bridge to be built that connects these two groups, these two people, these two systems that long have not had a relationship with each other, yet are dealing with much of the same people, and both of whom want a solution, and both of whom need each other to make this thing go, right? That's the whole point. Okay, we have finished a little bit early. I want to give you just a few stats. I'm going to use actually my final minute because I want to give you a few stats to know when I talk about the space of deflection, and I will finish right on time. So no worries, I got my clock here. In the United States, the average arrest rate sits at about 19%. This is about 1 out of 5 people are arrested. That means 4 out of 5 are not. That's the deflection space. About 60 million people are encountered by law enforcement every year in the U.S. About 10 million turn in and out of the jails. So that's about 5 out of 6, right? 10 out of 6 go, 1 out of 6 enter the jail. 5 out of 6 do not. That's the deflection space that we are looking for. And finally, an EMS stat, the national average, so this may not fit where you are, the national average in the US is it's about 7 to 11 times on EMS runs before someone's taken to the emergency room. And what we're trying to get at with EMS versions of deflection is that space that says, listen, those times where you're not taking them to an emergency room, can we do deflection? Can we do something different so we're not back here in a week and deal with the issue now? Okay, I'm going to stop. I am closing 15 seconds early. Thank you very much. I will stop share and participate in one comes next.
Well, thank you so much, Jack. This was a wonderful presentation, and I'm sure everybody enjoyed as much as I did. I'm going to open up the floor for some questions and comments from our learning community here. Yes, Abby.
Hi, I'm a recovery coach in the Hill Country, and I'm wondering, could you put a link in the chat maybe to more information about this program, or a nice video maybe I could watch?
Yeah. Yep, it's not, I want to say something. I appreciate the question. Thank you so much, Abby. We use the word Deflections Initiative, not a program, because what we're getting away from is kind of the box. It's really community partnerships that create it. I will put in the Fletcher Group, which does rural work out of Kentucky, very, very rural deflection. I'll put a very cool cartoon that they made about deflection. I'll put that in the chat box.
Thank you.
Yep, cool.
Diane.
Yes, thank you so much. This is Diane Thomas from Bell County Detention Facility. I understand this is an initiative and not a program. Is there any follow-up? Does the police department follow up with these clients that they're actually doing the referrals for?
Yep. Thank you for that question. It's an excellent one. That slide where I said deflection is 1/10 police and 9/10 treatment, housing, services, and recovery. The police don't follow up, and we don't want them following up, and they don't want to be following up because they have their work to do. It's the 9/10 that does the follow-up. In other words, the treatment, housing, services, and recovery and police are linked. I'm just going to stay within the law enforcement examples. They're linked. The police run into Jack and say, hey, I think Jack would be good for deflection. I can see what's going on here. It's early. I don't want to see Jack again in 3 weeks because it's going to be a bad day for everybody at that point. Jack is deflected, won't go into the mechanism of that. Deflection takes over. From there, they say, okay, good, officer, you can get back on, do what you need to do. We've got it from here. And they will then loop back in, however, with the officer to let the officer know, to let her know what's going on with Jack, because what we know is that the officer wants to know what's going on, doesn't want clinical, doesn't want medical. They don't care about any of that. They just want to know that it mattered that they did it. But otherwise than that, the officers do not follow up. Now, I want to say one thing, and I'll be brief on this. There are forms of deflection, because deflection is designed by each community, where the officers do, in fact, do the follow-up, but they're doing it mostly because the treatment housing services and recovery might not have vehicles to get around, right? Or might not know how to find someone after the deflection has occurred. But it's not the police leading or saying, okay, I got to do the referral and I got to do the deflection. That is no way to sustain anything. So they're sometimes ancillary. It's not to minimize them, but they're ancillary kind of to help out on the follow-up. But the interventions themselves, they're not part of that. They don't do any case management, thankfully, and I come from law enforcement, so I get to say that. They don't do any case management. They don't do any linkages to care. They don't do any clinical work because it's not their role or need. Nor do the treatment housing and services do any enforcement work, but they do partner together. They do stay in touch, and they do let the officer know what's going on with Jack. Does that help as an answer? Yep, cool.
Thank you. Arlo.
Hi, Arlo. Welcome in Houston. And Jac, number one, a lovely presentation. I really appreciate your concise review and the points you made. I guess one of my concerns is here in Houston, we have had, it started off as called the Houston Sobering Center. It has now become a much broader Houston Recovery Center. We have active outreach. It's the community. But
Cool.
Yeah, that is distinguished. And there's a national organization that does sobering and recovery centers, different from the program or the organization you mentioned, and that's been around for 10 years. But I just want to make sure, number one, is this an appropriate model? Is this what you're referring to? And number two, how is this parsed out between what currently exists, for example, in Houston? Is there a distinction between what you're describing? But I appreciate your thoughts and your comments. Thank you.
Yep, and thank you again for the question. Thank you, Arlo, for the question. Let me put it this way. Any community that decides to do deflection, because it's a set of relationships, really is tapping into something around law enforcement encounters, but the back end of it, right? That 9/10, the treatment housing services recovery. And again, that's just a proxy for the range of things that a community has as assets and resources. Those that are in play remain in play. Deflection does not seek to overrun them, go around them. It says, hey, we've now got this huge referral source called law enforcement. That's 60 million encounters a year. Fortunately, most people do not need either mental health, substance use, or housing. And we're going to leverage those encounters. So if you've got a sobering house going on, you've got that situation, or you've got like in Las Vegas, they've got a one-stop center, or like Chicago, which just says, we're going to have a variety of local resources. Deflection just leverages the contacts, but taps into the existing network. It doesn't compete with them. It probably will actually open up more doors that have existed for those community resources, because many community resources in the U.S. generally have not had a strong relationship with law enforcement and vice versa. So I hope I answered the question. If I missed it, try again. I apologize. If I did.
I think you covered it. I would just say, if people are interested that are here in Texas, the Houston Recovery Center, it used to be, did create this if there is a resource or a model that, but you're right, it's got to span the spectrum and not displace anything as much as collaborate with existing services.
Right. It is a collaborative community framework of organizations that relate together to say, we're going to solve a problem. This problem is going to be early encounters around addiction. That's what it's trying to solve. That's it, solve for X, as we learned in 3rd grade.
Thank you. Esteban.
Thank you for your presentation. My name is Esteban Romo, recovery coach with Sakara in San Antonio. And it helps me understand that this process of deflection. And I noticed that on the slide, there was we meet them where they're at. Okay, and through this, we don't leave them where they're at.
Correct.
Right? Okay.
Yep. And Esteban, I appreciate the work you do. Deflection has a phrase that it uses, which is called relentless engagement. Deflection really, and all of you are experts in this, you know that when you encounter people, whether it's law enforcement or otherwise, who are not at a crisis stage, because again, we're trying to get upstream from that and that what we really need is engagement. The research bears that out, right? People don't necessarily need a bed, right? SAMHSA's data is about 20% of people actually need what everybody calls a bed. We know why they want a bed because they've burned bridges, but that's not what clinically is needed. They might or might not be ready for nor need outpatient. We don't know. What we do know by the research is that engagement with that person, exactly what you're saying, is what we're going after in deflection. Get to them early, begin the process of engagement. Maybe 3 months later, they'll be ready. What is the difference is without deflection, 3 months later, they'd still be on their own. With deflection, they at least have someone who's checking in to see what's going on, how are you doing, can I help you? And by the way, we find, and the data does support this, that for the most part, and you guys know this, when you're not in that crisis space, many things are actually resolved just by helping people get through systems, talk to someone, help them along, fill out forms. Deflection works in the field, it's in the community. That's a lot of what people are just struggling with. And then if they need treatment or something more, deflection helps them access what is a very challenging thing to access, right? It's just not easy to get into treatment otherwise.
Thank you so much. And thank you, Jack. This has been a wonderful discussion in lieu of our time. We have to move on to the next part of our session, but please keep the questions coming. We can continue this discussion in the chat. Karen, if you could please share the announcements from the BWell program. Thank you. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive expert feedback from our hub members. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your presentation. Please email us at cstat@utisca.edu. Next slide. The Texas Substance Use Symposium is happening on February 29th and March 1st, 2024 in Austin, Texas. Our in-person registration for the Texas Symposium is sold out, but the virtual spaces is still available. So please visit texas.org for more information. This is a free symposium. Next slide. Join CSTAT and the Texas Health and Human Services for our session titled Stigma, COVID-19 and the Impact on Substance Use Disorders and Overdose. This will be on Wednesday, February 21st. To register, please visit our website at cstat.utisca.edu, and we will be dropping this link in the chat. Next slide. Please join us on our next session on Thursday, March 14th. We have an interesting session lined up. And with that, we will move on to our case for today. Karen, if you could please bring up the case form, and Shannon, you can take it away.
Okay, great. Hi, my name is Shannon Churchwell. I have been with the fire department for 19 years. About 12 of that in EMS, and within that, about 4 years with the mental health aspect and actual drug and substance abuse teams as well. So enough of that. We have I guess about a week ago, I received a call. I am with the communications division for the past year now. Received a call from a female. She was approximately 25 years old. She was in a very emotional state. She was expressing her feelings of despair, suicidal ideations, something that she has struggled with in the past. She had been drinking alcohol, but unbeknownst to me, until about several minutes into the conversation, she had been sober for a year. She was locked out of her house. Her husband was inside. She was not from the US. When I asked her if she had any resources, if she sees a counselor, if she has, if she's seeing anybody about the alcohol issues that she's having, and she said no. She was from Canada, and she didn't have any resources. So I kept her on the phone, dispatched. We as a team, we send out the police department first to make sure that it is a safe scenario for us to be in, because we don't have means to keep ourselves safe. So thank you for the police department for helping us stay safe on scene. I did dispatch them, and as I was talking to her, she was just in complete despair. found out that she had been drinking, unbeknownst to her husband, and she had no counseling, no assistance, and anything of that matter. She did, at the time, it was very late in the evening. Unfortunately, the response times for the police department and that aspect for psychiatric calls are kind of a low priority unless they are in direct, harm of themselves or other people, and she was not. She did express that she did not say that she had a plan of action or anything. She was just feeling, despair. Police wait times are kind of a concern for us because people do call back. We did not have core on. We have a core team. I was unaware if she was involved in maybe a domestic violence situation, relying solely on her husband's insurance, which had not kicked in for her, was a barrier for her as well. Something that we would like to use Right Site for. I don't know if everybody's aware of Right Site. No? Okay. So we have a program that is extremely new. I mean, within the last couple of months, where us as clinical dispatchers can take a call and say, I can handle this right now. I can actually do a one-way video chat. I can take with biometrics some basic vital signs to make sure you're okay and see you and talk to you, and they feel seen. Even though they can't see you, they feel seen. Well, fast forwarding to something that maybe they just need some mental health support. Maybe they just need something for back pain, whatever it is. We can forward that to a program called Right Site. A navigator answers the phone and gains their information and permissions, and they're transferred straight to an ER doctor that's waiting to talk to them, so they can get immediate assistance. So that's something that is not available to us past 10 p.m. and this call was about 1 a.m. So there was a limitations to issues with that. She did call back. After she called back, her husband was now on the line and he was very upset that anybody was responding. And that's where I felt like possibly there was a domestic violence situation or a controlled situation where she is from Canada. She just moved here about 1.5 to 2 years ago. She doesn't have insurance, relying solely on him, which is unfortunate, but it is very common. If we had core for that softer approach, our core teams handle mental health live calls. We do have a PIC team that handles, after the fact with mental health patients and clients, but that core would have helped soften. They're in uniform, but they're in a gray uniform as opposed to something with a badge and a gun, which would be police department, which handles that. So I feel like those things implemented would have been very helpful. In a perfect world, of course, she would receive, counseling for the mental health and she wouldn't have to rely on him. She was very open and accepting to receiving help, and she was very kind. The outcome to that was that it did get passed to the police department. She was canceling us on the fire side. The police department will request us on scene if they need us to establish that she is medically okay, if she is well enough to be taken to maybe a mental health facility or a hospital for evaluation. So that's what I have so far. If anybody has any questions, I kept it very minimal because I'd like it to kind of paint a story and tell a story instead of just reading off of something.
Let me put in a couple things.
Okay.
So this is Dave Miramontes. I'm the medical director of the San Antonio Fire Department. So real quick, what this brought out is that we can reach people in different ways. In this case, we had one tool in the toolbox that we could use, and that was a police response. Probably not the best tool to use in this situation, but the only tool we had. And I think what this brings out is we need to develop more tools in our toolboxes. And actually, Shannon and I were talking about this earlier. Maybe a referral to Psychata, maybe a next day follow-up referral for our polysubstance team, maybe XYZ, but having more tools in our toolbox is what we learned from this case in dispatch. And I think that that's the point of this, is that we recognize that we have a client in need and we weren't providing for her needs. And so we need to develop our toolbox just a little bit better, or at least have an awareness. Now, thank God Shannon was working on comms that night, because she knows the resources in the community inside and out. Some of my other dispatchers may or may not have that experience and may not have reacted in the same way. But that's the point of this case, is open up discussion that you need to have the right tools in your toolbox, and more importantly, know what tools are there and how to use them. Because if you need a ball peen hammer, you shouldn't be using a sledge. That's the point. So we'll open it up for discussion. Does anybody else have any other suggestions, a different way of handling? Obviously, this is a deflection, which is what we talked about. In a way, we tried to do an deflection, but then we ended up calling law enforcement anyway. She didn't engage in the law enforcement world, or no arrest or anything. So in this case, it was a deflection, but it could have ended up being a post-arrest diversion instead. So unfortunately, we need to look at how we can use our tools better to do deflection, not diversion, as we heard in our previous case.
Thank you so much, Shannon, and presenting the case. I will open up the floor for questions and comments.
My name is Esteban Romo, recovery coach with Sakata. And we do work hand in hand with the MI page. When we get a referral from them, San Antonio Fire Department, from John, we do follow up on their referral and offer them whatever services they may need, whether it be for MAT, MOU, and we just follow up with them and encourage them. We become their network of support. If they don't have one, we start building a network of support. So we do enjoy going out with the ride-alongs with them, and we do share our lived experience with those participants that we are allowed to talk to. And it's very, very encouraging to know that some of them are willing to engage in a journey of recovery, and others, of course, are not. But we don't give up hope working with them. So thank you guys for the work that you do, and I really appreciate it.
And thank you, Esteban. Thank you very much, Esteban, because I've worked with you hand in hand and we have done some good work together.
Thank you. Jack.
Yep. So thank you for letting me participate in this, by the way. I just have a question on the case itself. Had you received calls, or had EMS or somebody else been there before to that address, or to encountering this person?
That is a great question. That is sometimes one of the first things that I look at to see if there's been anything there. I did not see anything that was prior or previous, which was helpful to me, knowing that she's new to the country and there's not a lot of, there's no domestic violence situation going on. There was not a lot of alcohol or issues, law enforcement wise going on.
Yep, good. So I appreciate that. I'm not here to sell deflection, right? Deflection's not like the one trick pony that does all the magic and works in wonders. And I say this because I do work on the diversion side also. So I work the justice side too, is what you've described. And I think, someone said it really does have like shades of deflection all over it.
Sure.
we have this encounter occurring, and we want to do something different. And so, anyway, just a comment. Yeah, totally. We all understand the complexity of these, but it is a good deflection case that you have described. And if there had been earlier contacts, you know what I was going to say, which is it's on those earlier contacts, so we don't have this contact. But I understand and I get it. Yep.
I have a question. Just really quick. I think that it's important that there has to be some type of an infrastructure or some type of for initiative like this to have, I don't know what I'm trying to say is that maybe some recognition from all different parties before any arrest, so that at least everybody's on the same page about how deflection would work and who the contacts would be to move on. And I think that adds on to what Dr. Miramontes was saying. It's like we got to build that toolbox and those services to access quickly.
Yes, you are absolutely right. I told her even on the phone during the call, I said, you somewhat lucked out with me having the experience in the mental health and with substance abuse, which was helpful to her, but how many other calls are slipping through the cracks because we don't have the correct, we have the resources, but not everyone is keen on the resources. And so that's what I would like to do, is I was talking to Dr. Miramontes about that, putting together some resources that we can give to them right then and there. I mean, from the beginning. And sometimes that actually stops a law enforcement response or even an EMS response when we can get someone from CORE or Right Side or Cicada to them within, 12 to 24 hours. That's very helpful.
Deanne?
How often do you see that the referrals are being made and the services are declined? So once you guys make the contact, you guys make the referral or the deflection, and then the person declines any type of assistance. What's next?
80%.
So there is a follow-up. We do have teams that follow up. I am just happen to be on the initial side, the dispatch side, and I'm also on those teams, which is extremely rare. There's only 2 of us that are in communications division, the dispatch division, that are also on those teams. So about 80%, I think, is what we're looking at that actually, go ahead, Dr. Miller.
Yeah, so the San Antonio Fire Department does around 3,200 overdoses a year. We reach with our outreach team about half of those, and a very small percentage are ready for recovery and actually enter treatment. But that's not to say that we don't triage them. It's less than 19% going to treatment. But at least that we've given them a touch. We've given them, hey, these things are out there. And sometimes they require multiple touches before they're going to reach out to a peer counselor. A lot of times we have to get peer counseling involved to try and get them primed and ready so that then they can go into recovery treatment services. And of course, if they're homeless, the most important intervention for those who use drugs is to make sure they have safety, security, housing, food, and shelter first. So shelter first, then go into therapy or medication therapy, because they're just going to slip back if they don't have their Maslow's lower level Maslow needs met first. They can't attend, they can't focus. If you're thinking about food, shelter, and safety, you're not going to be attending to your recovery process. So very small portion. But the point is to touch, triage, refer, follow up, and hopefully get them into peer counseling or other different ministries like Corazon, Haven for Hope, SAM, Shelter, wherever, or the Cicada, and try and get them engaged in our community treatment. Kind of do a little deflection before they get into the justice system. Unfortunately, if they make it in the justice system, the patients are really at a disadvantage.
Yeah.
There is no treatment with buprenorphine or morphine in the jail. A lot of probation folks that we've talked on this forum don't know about medication assisted treatment and actually will make it a condition of violation if they do that. So unfortunately, our justice system is not there yet in our community, even after deflection, even after diversion, though we have drug court and some other diversion techniques. Sometimes that doesn't work out so well for the client.
And if I can just jump in, and those are great comments. And again, this is not, Jac's one trick pony called deflection that I, bring around every so often. The fundamental idea of deflection, as you heard me say, is we get to people earlier. So whether you think of the case you're talking about now, and again, if there were at least no previous, calls in, somebody else might have been touching it. But the point is, what we also know, and you all know this, is that when we get to people earlier, some of these interventions, we say, oh, we don't have enough of this, we don't have enough of that. I want to repeat again, they actually might not need that when you get to them earlier. They just need engagement, and that can solve, and we know this, that can solve a lot of things when you get to people early versus, hey, now the only time we're getting to them is, pre-crisis, in crisis, and around that space. And hence, of course, the interventions are expensive. They take time. They're short on waiting lists, stuff like that. So we do find in the deflection space, again, it's not mystical magic. It's, oh, you just, you lost your job. You went out, you and your wife got in a fight and you started drinking. That's a different space than you hit your wife. It's been a month. She kicked you out and now you're on the street. Those are two very different spaces and they're both real. Unfortunately, that first one is the one we're trying to get to earlier. And by the way, law enforcement EMS is already having those encounters based on the statistics I told you. They just don't have anything to do at that first point. They do have something to do at that second point, and it's not of anybody's interest. Anyway, just great comments from Fire too. You guys are usually spot on this stuff.
Thank you.
Thank you so much. And with that, we will be closing the session. Dr. Miramontes, if you could please summarize the session.
All right, so I'll be real honest. I never heard this deflection concept in my space, and I don't think a lot of us have who are on this call. So great information about deflection versus diversion. Deflection being law enforcement intervention and ways to keep them out without arrest, without adjudication, and get them into a community base where focus is on well-being. And it is a crime reduction model because we're keeping them out of the justice system versus jail diversion or pretrial diversion versus post-jail diversion or whatever, which is a law enforcement based process. We learned that that deflection is more family-based and community-based, as opposed to in the justice system where diversion is law enforcement individual-based. And I think that's a big thing, or kind of flip our mindset a little bit about where we are in those two worlds. Both are going to exist because once you get into the justice system, we have to get you out. But this new concept of deflection, of intervening early. Another, in our world, we call this harm reduction, right? Where the harm is we're keeping them out of jail, right? We're doing harm reduction to prevent death, disability, infectious disease, et cetera. But also our harm reduction techniques are keeping you out of jail because jail is a bad place to be and actually causes a lot of harm financially, socially, in the family. And then, of course, the hazards of punishment that occur. And we all know from this call that punishment does not teach you new skills for recovery. It just makes your life worse when you're a person who uses drugs who ends up in the judicial system. We've got some good facts and figures. Shannon's case, we summarized real quick, was a comms. She took the 911 call and did some deflection initially, but then we had to actually have law enforcement be our first responder to try and mitigate that, because that was the only tools that we have. But now we have more deflection tools that we've talked about that we could potentially use in dispatch, and hopefully to keep these calls from going to a fire truck, ambulance, or a police officer, and instead we can route them to other agencies in our community that can do good work. But otherwise, great discussion and good questions in the chat, and we'll send it back to you.
Thank you so much, Dr. Miramontes, and thank you all again for joining today's session. As a reminder, to earn continuing education credits, please complete the post-session survey in the chat. If you would like to present a case, please email the BVAL Texas team at cstat@utisca.edu. We look forward to seeing you in the next session on Thursday, March 14th at 11 a.m. Central. Have a wonderful rest of your day. Thank you.